Dear ESTS members and webinar attendees, as you already know, my name is Lieven de Piepere. I am a member of the ESTS Learning Affairs Committee, webinar coordinator and moderator for today. This is a webinar of the 2018-2019 series. The last 3 webinars had over 200 registrants each and about 100 live attendees each. Today will be about how to streamline minimally invasive esophagectomy. I am very proud to introduce you to Professor Zhigang Li as a guest speaker. Professor Li is Associate Professor at the Yao Tong University in Shanghai. He's Deputy Director of the Department of Thoracic Surgery and Director of the Department of Esophageal Surgery in Shanghai Chest Hospital. He is so kind to give this lecture in our webinar series by live streaming when local time in Shanghai is 1:00 a.m. Please, Professor Li, the stage is yours.
Thank you, Lieven. So everybody here on the screen, it's my pleasure here and to share our experience for the minimally invasive esophagectomy. Actually, I know for the histology type between Europe and China is a little bit different because in China, more than 19% cases is a squamous cell esophageal cancer, but in Europe, maybe more the adenocarcinoma. So I think maybe today I can give you the experience of ours for the MIE, but it's more for the squamous cell esophageal cancer. So I hope I can bring my experience, but cannot give you some confusion because the histology type difference. Okay, Lieven, can I just start my lecture?
Yeah, I just published 3 polls because you had a few questions for the audience. Huh? We have 3 questions. You can see them for the audience. You can see them in the right sidebar. So the first question is, what is the 5-year overall survival in your surgical patients with squamous cell carcinoma of the esophagus? The second one is, what is your treatment strategy for approaches of squamous cell carcinoma? And the third one is, what is the proportion of squamous cell carcinoma patients undergoing esophagectomy in your center? So you can vote, and then we will see how it is in Europe. And then Professor Li can comment a little bit on that. And then we can start, I think. Huh?
Okay. So maybe we can start the lecture first, and maybe at last we can just give my comments for this question.
Okay.
It's okay.
Perfect. Yes. Then people have time to vote in the meanwhile. Yep. So please, you can start with your talk then.
Okay. Okay. Can you see my slides?
Yeah, it's perfect. Thank you.
Okay. Okay, so today my topic is how to streamline minimally invasive esophagectomy. So although our topic is it, but we still cannot change the fact that esophageal cancer surgery is one of the most complicated operations. It involves resection and reconstruction. It needs to span at least 2 or even 3 anatomical regions. So for today's speech, there's no disclosures. So minimally invasive esophagectomy began in 1990s, and thoracoscopic esophageal surgery in China was basically synchronized with the international practice beginning in 1995. But due to the technical challenge and limited equipment, it was not until 2006 that a large group reports appeared in China. However, in the second decade of MIE surgery, many large group reports appeared in China, and MIE has been performed in many large centers as a routine operation. Last year, we can see more than 590 patients underwent MIE treatment at Shanghai Chest Hospital. And from this slide, we can clearly see how important MIE has become in our daily work, and traditional thoracoscopic and robotic-assisted MIE has accounted for 82% of all esophageal surgeries in my center. So I will complete today's speech in 3 parts, so including the philosophy of MIE and surgical techniques, and finally the data results of MIE in the Shanghai Chest Hospital.
Okay.
So in the treatment guidelines from NCCN, it's difficult to find detailed surgical recommendations for esophageal cancer surgery. So they just taught us to selective favored approach and a selective favored candidate and at least 15 lymph node dissection. But in China or in Asia, the focus of esophageal cancer treatment is very clear in the more thorough lymph node dissection. So this is almost the top priority of esophageal cancer resection. So previous clinical studies verified that anatomical knowledge for lymph node metastasis in esophageal cancer. So in patients with tumors limited within the submucosal layer, lymph node metastasis was frequently present in the upper mediastinal and paragastric area. But when the tumor invades or penetrates the muscle layer, the frequency of paraesophageal lymph node metastasis or paratumorous metastasis in the middle and the lower mediastinal is increased. So therefore, whether it is superficial T1 or advanced T2 to T4 esophageal cancer, extensive lymph node dissection is mandatory for squamous cell esophageal cancer treatment. So where is the area we need to focus on dissecting? So here the data of lymph node metastasis distribution from Shanghai Chest Hospital. So if we cite 5% to be the critical value of dangerous metastatic importance, then the important areas above 5% are as below. So first is the right recurrent laryngeal nerve, the second is left recurrent laryngeal nerve, and then it's a pericardia and the left gastric artery, then it's the middle and low paraesophagus and the paratracheal area. So these stations are the focus of lymph node dissection during operation. But this is just numbers, so we should try to connect it to the survival or to the cost effective. So Japanese doctors have designed an efficacy index to describe the importance of lymph node dissection at each station for long-term survival. So if we take the 2R lymph nodes as an example, so actually 2R in Asia we call it recurrent laryngeal nerve lymph nodes. So the first column on the left is we have 100 patients. The second column is after operation, 20 patients were found with node metastasis at 2R, which is 20% of a metastasis rate at this station. So the third column is the 10 of the 20 patients with lymph node metastasis at 2R has lived for more than 5 years. That is 50% of 5-year survival rate. Then the EI index for this position 2R is 20 multiplied by 50 and then divided by 100. So it is 10.
Okay.
Okay, these slides show the areas where we should focus on the lymph node dissection for middle esophageal cancer, this very common location. So the order is 2R, 2L, para-EJ junction, left curve, and left gastric artery, and the middle and low esophagus. So it is because the focus for the thorough lymph node dissection, we have achieved good long-term survival results. So we can see in Shanghai Chest Hospital, 5-year survival rate of esophageal squamous cell carcinoma has reached to nearly 50%. So now we move on to the technique of the MIE. So what kind of patient's position is best for thoracoscopy? Because we usually use the McQueen approach, so we start from the thoracoscopy. So because the most valuable and difficult lymph node dissection in the chest is the right and left recurrent nerve, so our precision design is based on those two parts. So we need to make the operator feel comfortable, but also to have a good surgical exposure. So if a 19-degree lateral position is used, so the surgeon's arms are almost the same height as the shoulders. So the surgical instruments are almost vertically close to the mediastinal and the comfortable is low. So when the prone position is utilized, the surgeon can sit to complete the operation. So it is usually used by Japan doctors. So moreover, any bleeding in the mediastinal can flow to the lower pleural cavity, and the surgical field would be very clean. But for this position, the anesthesia management and the intraoperative conversion would be very difficult. So considering the safety of the operation and the comfort of the surgeon, so in the Shanghai Chest Hospital, we use a semi-prone position, and the surgeon stand on the abdominal side of the patient, and full pulse were used. This is our design for the surgical phase of MIE. So McQueen approach is always be used for every patient for the bilateral lymph node dissection at the mediastinal. For the Lewis approach, we always think we cannot do a thorough lymph node dissection for the upper mediastinal because we worry about the bleeding, we worry about the ischemia for the esophagus. And CO2 is insufflated at the pressure of 6 to 8 mmHg to expand the mediastinal. So insufflation depresses the diaphragm caudally and pushes the lung anteriorly, so maximize the exposure of the intrathoracic esophagus without the need for additional retraction of these structures. And a single lumen into trachea tube with a blocker in the right main bronchus for the single lung ventilation can make the trachea soft and flexible for the bilateral dissection at the left recurrent laryngeal nerve. And in the chest, we use modular surgical procedures operating in the following order. So first, we start from the right recurrent laryngeal nerve, lymph node dissection, and then to the avagous nerve dissection, avagous vein dissection. I'm sorry. And the third, we do a middle and low esophageal dissection. The fourth, we do the left recurrent laryngeal nerve dissection. And then we end for the subcranial lymph node dissection. Okay, this is a video of the right recurrent laryngeal lymph node dissection under the IgG trees. Living?
Yeah.
Can you see the video? It works well? The video is okay?
It's slow, but it's okay.
It's okay, okay. So of the metastasis lymph nodes would located behind the vigorous and recurrent laryngeal nerve, but the nodes of lung cancer are located before this boundary. So this is different from the lung cancer. So the predictive value of ICG on the sentinel lymph nodes in esophageal cancer remains unclear, but our preliminary results show that it has a very good negative predictive value. So we usually use more blunt dissection and clips and scissors to minimize the nerve damage. And the right recurrent laryngeal nerve dissection can be extended to the neck. So therefore, the current neck part of the three-field lymph node dissection is only performed on the bilateral supraclavicular areas, and the periesophagus usually can be completed in the chest. Mm-hmm. So from the video, we can see the ICG can mark the lymph nodes very clearly, and they can just guide our dissection. Because usually some very small lymph nodes, usually maybe less than 5 millimeters, If we don't use ICG, maybe we miss it. But under ICG guide, we can see it very clearly and very beautiful, just like the art.
How do you inject the ICG?
It's just some mucosal use endoscopy.
Before you start the operation?
Yes, usually 10 minutes before the operation.
Okay.
Okay, this is a left side lymph node dissection for the recurrent laryngeal nerve. Because most of the laryngeal nerve injury MI occurs on the left side. So mainly because the left recurrent laryngeal nerve path is very long and the lymph nodes are distributed along the line. And the trachea obstructs nerve. So it is difficult to expose. And the cardiac branch of the sympathetic nerve. Let me play the video. The cardiac branch of the sympathetic nerve will also interfere with the positioning. So as the table shows in these slides, we can see in our previous study, in the group of patients we reviewed, the left side of the injury usually account for more than 80% of all injuries. So it's really a dangerous place. Yeah. So therefore, in this part, we need to be more careful and use more blend separation and use field energy equipment, just like a harmonic. Because of use of single lumen endotracheal tube, the assistant can gently press it to one side and have exposed the recurrent nerve and the lymph nodes. So if we use a harmonic to do the dissection, we usually put the working branch just far away from the nerve. So just try to decrease the instance of the injury for the nerve. Okay. So I know in the Western world, North America and Europe, usually the surgeon doesn't like to the naked lymph node dissection for the nerve. But in China or in Asia, we usually like to exposure for the nerve, and we think the more clear exposure we can achieve a more protective results for this nerve. Mm-hmm. And we can see there's several nerves along the esophagus, but usually there's one is a branch of cardiac branch of the sympathetic nerve. So like these slides, we can see there's a cross. So this one actually is the cardiac branch of sympathetic nerve. And this one, parallel to the esophagus, usually is the recurrent nerve. So we need to protect this one. Okay. Okay. This is tables. Okay, for the esophageal cancer, subcranial lymph node dissection is controversial. It has been reported that the metastasis rate at this position is between 5 to 9%, so our number is 7%. And the EI index, the efficacy index, is less than 3, so it's not very important. However, due to the rich distribution of the bronchial arteries, the bleeding rate during operation is extremely high for MIE. At subcranial positions. So, and the left bronchus injury is the most common intraoperative complications of MIE. So therefore, our recommendation is to be particularly careful in this position. And for the upper esophageal cancer, T1 lesions and the lesions less than 3 centimeters, according to our previous study, there's almost no metastasis, so which we can avoid to do a lymph node dissection for subcranial.
Not only the hilum, but also subcranial.
Pardon?
Not only the hilum, but also subcranial. You don't do this in small lesions.
Yes. No, in my center, usually I do it because we think we are the reference center, so we need to accumulate more data. But actually, I think for the T1 lesions, we needn't do subcutaneous lymph node dissection because very few for the lymph node metastasis. And the ICG study, so we performed also show there's no connection for the lymphocyte, for the lymph nodes connection between the esophagus system and the pulmonary system.
Okay.
So total mesoesophageal esophagectomy is recommended as the best surgical principle for esophageal squamous cell carcinoma, and the thoracic duct is included in the mandatory, but it's not widely used because it maybe bring some complication. So previous studies have shown that thoracic duct resection in patients with stage T1 seems to be more beneficial for the long-term survival. So this is a video in this slide shows the process of robotic assisted esophagectomy, and the lymph nodes along the thoracic duct appeared clearly. So here is the lymph nodes. So for such cases, we usually like to do a thorough thoracic duct resection with the paralymph nodes. And recently also there is some other reports from the South Korea. They also think for the very early stage esophageal cancer, for T1, even for T1A, they also do a thoracic duct resection. They think this procedure can make this early disease to be a really curable disease. So we can see in the robotic, the procedure is very, very easy. We can do a thorough, total thoracic duct resection and very quickly.
Okay.
And we can see there is a lymph node just to pair the thoracic duct. So here are the lymph nodes. So we do a resection. Okay, just a question I present at the beginning of this speech. So induction therapy has become one of the standard treatment strategies for resectable esophageal cancer, and thus has become a common condition of MIE. So on our experience, usually we show that for the early T-stage patients, induction chemoradiation has no effect on the surgery. Just like the left side video, we can see after chemoradiotherapy, usually there is a little bit tight relationship between the esophagus and strong tissues, but it is okay. And we think on sometimes after induction chemoradiation, even a more blood-free surgical field can be gotten. So we can say it is easy. But however, if the patient with a progressive T-staging, T3 or T4, or even the patients with a bulky lymph nodes, like the right side video. So the benefits of IME surgery remains to be confirmed. Maybe open can have the most safe results. So for this video, we can see this case with upper thoracic esophageal cancer, the tumor located just upper mediastinal. So after induction chemoradiation, we can see the lymph node still there, and it's bulky, and actually the lymph nodes totally surrounded the nerve. So we need very carefully use the scissors to do a dissection and to find the boundary between the trachea and the strong tissues. So actually we can see with assistance from press for the trachea, we should dissect it to the anterior part of the trachea.
Okay.
And usually there's some bleedings, but for these procedures, we have not enough time to make the surgical field very clean, but we only can depend on our experience to do a dissection by the scissors. But for such case, usually we need to a small sternotomy when we turn over the patient to the supine position, so to better exposure for the upper part of the dissection, I mean lymph node dissection. So I mean, we can do it, but I think maybe we cannot confirm it is much better than the open procedures.
Don't you see any problems in vascularization of the trachea, because the posterior side is completely free, the lateral left and right also? If you also free up through a small sternotomy the anterior side, then you have a circumference of the trachea that is not having any blood supply anymore. Do you see any problems in that?
Actually, it's okay. We have never just encountered some very severe complications. So usually it's okay, because if you use a single lumen endotracheal tube, so the trachea is very flexible, so you can press anteriorly, so we can expose this space.
Okay, but afterwards you don't see any fistulization or something because of a lack of blood supply?
No. Yeah.
Okay. Please go on.
Okay. So now we move on to the abdominal phase, because for thoracic phase, we usually think the lymph node dissection around the recurrent nerve is much more difficult. So if do it okay, so I think we can move on to the abdominal phase. So this is a very interesting paper just published in the New England Journal of Medicine. And they found a minimally invasive approach to the abdominal phase of an Eva Lewis two-fuse abdominal and thoracic esophagectomy was associated with substantially lower major morbidity, especially for the pulmonary complications. This slide shows our technique for abdominal phase of MIE. Usually 5 ports are used for laparoscopy, and the patient is placed on supine position and CO2 used in 14 mmHg, and the surgeon stands on the patient's right side. But if you like stand in the middle of 2 legs, I think it's okay too. And for the abdominal operation usually consists of two parts. So one is the stomach conduit harvest, and the other is the lymph node dissection. Actually, the second part usually is more important for the squamous cell esophageal cancer treatment. So we don't have too many abscess patients. I mean, it's a big billy. So the difficulty of abdominal operation will be reduced. It's not very difficult, I mean. But because in the Western world, the esophageal surgeon usually have a very extensive experience in the anti-reflux surgery, so abdominal operation is usually very easy for you. So I think it's not a problem. So this is a lymph node dissection along the left gastric artery and along the cardiacs. Mm-hmm. So we can see we can do the dissection. Because our patients usually a little bit thin, so it's a little bit easier.
What is the mean BMI of your patients?
I mean, thin. It's not big belly.
Uh-huh.
I just wonder, maybe in Europe you like the hybrid procedure for MIE, but in China we just do it total MIE because maybe because our patients is not abscess and not with a big belly. Okay, next I like talk about reconstruction because usually we like use the McQueen approach. So usually the anastomosis was performed at neck. So we like to make another small incision under the xiphoid in the abdominal for the production of a tubed plastic. So which may be a little bit confusing for the Western doctors. So they usually ask us why you do this small incision, but we are still using it for reliable esophagus institutes production. So usually we like do a very narrow candidate diameters. So usually maybe just 4 centimeters. And another point we should focus we do as much as possible lower level release, just like the Coker procedures to make the stomach is more very released. And we do the anastomosis usually is very high, just like this picture I showed. I like to do it very close to the orifice of the esophagus because if there's a leakage, usually the leakage can localize in the neck and not in the mediastinum, not in the intrathoracic. So it's very safety for the reconstruction. So this slide shows a learning curve for anastomosis. At present, the incidence of anastomosis leakage has stabilized at around 5%, and the severe intrathoracic fistula is rarely occurs in my hospitals. Okay, this is a third part of my speech for the data of MIE. So this is a retrospective study of comparing the long-term survival between MIE and open in all centers. So after the parameter matching, we can still say that MIE can bring statistically better long-term survival outcomes. Yes, however, it should be known that the two groups of patients, I mean, MIE and open, are not balanced from the same surgeon, because MIE is used more by me and my team, and open is used by other surgeons commonly. So there is a significant bias. But at least we can see that in the cases of prudent operation, MIE can bring satisfactory survival benefits. But we are still looking forward to the RCT result in Japan because they're just conducting a RCT trial comparing MIE and open. So we are looking forward to their results. So next, I like talking about robotic assisted MIE because robotic assisted MIE is far less popular than the traditional thoracoscopic surgery, but because of its very good flexibility and robust are very good for the better operation in the narrow space, especially for the lymph node dissection around the recurrent laryngeal nerve. So due to the limited time, I have no way to introduce this technique in detail, so only can show a video for the right recurrent laryngeal nerve lymph node dissection via the robot. So we can see we can use different instruments, device to finish this robotic assisted MIE. Just like we can use the Maryland, this bipolar instruments is very practical for the nerve. And we can do a very careful exposure and assisted exposure, just like a traction for the nerve. So now we like use scissors to do the cold weapon to do the dissection. So it was very safe for the nerve. So we can see here is the lymph nodes. This is the lymph nodes. So we can use a scissor to do a very careful and very clearly dissection, because under the robot, there's the circuit field is very good. So usually some doctors will ask, oh, on robotic, there's no feedback for the feeling, so how can you control the safety operation? But I think the good view, the surgical exposure is best feedback for the surgeons. So you needn't touch and you needn't feel it. You can watch it very clearly. So we can see the scissor can use the very smooth. It's very good. And we can see here is the nerve, and we can cut off the branches to the esophagus, and we can leave the nerve on the top, on the bottom of the surgical field. We can go up to the neck to do a thorough lymph node dissection.
Very nice.
Yes, it's very clearly. Yeah, this is branch to the esophagus. So Maryland is a very good instrument for the robotic, but sometimes because usually you need a cautery and then you need to cut it down, but it's not as good as scissors. So we usually use the scissor and the Maryland on the same time, so you can do the cautery and then you can do the card.
Mm-hmm. It's bipolar then or unipolar?
Yes, the Maryland is bipolar, but the scissor is unipolar.
Yeah.
Okay. Okay, this is some data for the robotic esophagectomy. So totally we have completed 380 cases of robotic assisted minimally invasive esophagectomy for squamous cell carcinoma, which may be the largest single center results for this histology in the world. And this is a retrospective study of robotic versus thoracoscopic esophagectomy. We can see robot can bring shorter operative time and more lymph node dissection and faster post-operative recovery. There are no difference for the complications between two groups, but the robot group had a higher rate of recurrent laryngeal nerve injury. So this is proved by the endoscopy, not only for the voice change. So we considered possible more frequent use of any device. I mean, maybe the scissor, unipolar, or the bipolar. But even there's a VCP, but this VCP, I mean, vocal cord paralysis, usually were temporary because the previous slides has shown that the post-operation hospital stay of the robotic group is even shorter. So we call it a harmless VCP, I mean harmless vocal cord paralysis. So with the use of few energy device, I mean we just use scissors, we just use the blend dissection. Our current vocal cord paralysis rate of our robot procedure has dropped to around 10%. So I think it's acceptable. This is a recurrence analysis because we only have not long-term follow-up, so we cannot do the overall survival analysis, only analysis for the recurrence. We can see the robot group was with less recurrence, especially at mediastinal. So we believe that the low recurrence rate of the robot stems from a more thorough lymph node dissection, because usually the local recurrence rate after operation account for 50% for all recurrence. But in our robot group, our local regional recurrence is much lower than the distant metastasis. So therefore, robot have an advantage on the local control of tumor. Mm-hmm. So now we are conducting a multi-center randomized clinical trial to compare the effect of robot and traditional thoracoscopic treatments on esophageal cancer. So it is expected that the enrollment will end this year. So we are looking forward to these results of this research. So our primary endpoint is the overall survival.
Okay.
Okay, this is my conclusion for this speech. It's very simple. So for esophageal cancer treatment, MIE technology is feasible and can be promoted, I think. And for esophageal squamous cell carcinoma, lymph node dissection is the core of IMI surgery. And for the IMI technology, I think robotically maybe significantly reduce the learning curve and improve the surgical outcomes. Okay, this is our esophageal section team. I'm not sure it's so many members. We also have an international fellowship training program, so welcome young surgeons or doctors who are interested and come to my hospital. So thanks for your time. And now I think I move the microphone to the moderator, Levin, and it is question and answer time. Thank you very much.
Okay, thank you very much. Very impressive, very impressive. Thank you for this very nice talk. I would ask the audience to ask questions. If you have any, you can do this by clicking on questions on the right sidebar. In the meantime, I think we can discuss the questions Professor Zhigang Li asked us in the beginning of his talk. And maybe we start with the first one. Maybe we, Professor Li, you should just click on your screen to that we see you a little bit better. That we can enable that screen sharing.
Oh, I close the screen share.
Yeah, like okay. This. Perfect. Now we can see you. So, can you give us some comments on the three questions? So the first one was, what is the 5-year overall survival in your surgical patients with squamous cell carcinoma in Europe? So this is quite equally divided. More than less than 30-40, and a little bit less 40-50, and more than 50. So I guess it will be around 30-40 for most of the. And even less than 30 for most of the patients in Europe. And I had the impression that it is certainly higher in China, isn't it?
Yes. So in my center, our overall survival, 5 years overall survival, actually is 50%. So I just wonder why in Europe or in North America for squamous cell esophageal cancer, the 5-year survival is usually not, as good as Asia, because for the Japan and Korea, usually the 5-year survival for squamous cell esophageal cancer after surgery usually is 50%. It's common numbers. So maybe I think for the Europe or United States, usually the patient condition is not as good as China, as Asia, because in China usually the patient could be a little bit younger. Because the average age in China, our patient is 60 years old. I just wonder how old in Europe, maybe older?
No, I think that's definitely something. Our squamous cell carcinoma patients are in a worse condition. The adenocarcinoma patients, they are quite okay, but most of them with squamous cell carcinoma, they are heavily drinking, smoking, and let's say that the average age will be around 60-65, but the condition, the main general condition is worse than in the adenocarcinoma patients. That's true.
Yeah, I think maybe this is a main cause for the worst survival. Yes.
And the second question: what is your treatment strategy for approaches for squamous cell carcinoma? And then let's say 2/3 says neoadjuvant chemoradiation followed by surgery. No neoadjuvant chemotherapy. I think indeed this is something we don't do in Europe. So chemoradiation in most of the patients. Some say surgery alone, but the ones that have surgery alone, they will have adjuvant chemo or chemoradiation therapy. Indeed, I think you have more primary surgery in China, huh?
Yes. Yes, there's we're just conducting some research for the induction therapy for squamous cell esophageal cancer. But now in my center, I think the induction chemoradiation only used for 30% of patients. It's not as high as Europe, because in China, usually some patients come from other places. so they will care about the economic conditions, a lot of reasons. But next year, we're just going to conducting a presenal trial. This is yearly, actually collaborate with the Netherlands surgeons. They was idea, so I think maybe we can update the induction chemo to a higher numbers. I think it is the future, so we will do more.
Okay, and then the proportion of squamous cell carcinoma patients undergoing esophagectomy in the center. This is really something that seems to be difficult here in the audience. Let's say that in Western Europe countries, that will be not more than 20-30%, but it depends a little bit on where you live. For instance, the people from Lille in the northern of France, they have more than 50%. It's a little bit depending on the region, but normally spoken, there's more adeno than squamous cell carcinoma patients.
But I think this number is a little bit higher than I expected. Actually, in my mind, I think maybe a little bit lower. So I like you have more squamous cell carcinomas because maybe we can have more collaborations in the future. I think
that's it. I think now you have the selected public of thoracic surgeons watching you for the esophageal part. I think if you ask all esophageal surgeons in Europe, being mainly visceral surgeons, then you will see other numbers, and the visceral surgeons will do less squamous cell carcinomas, I think, because it's higher up in the chest. They do more adenocarcinomas. So this is a little bit more than you expected because it's a selected audience of thoracic surgeons. That's in my opinion.
Yeah.
Okay. So we already have some questions. We can discuss them in a minute, but I'll fire two new polls right now because I was interested in what you told us about the subcarinal dissection. Subcarinal dissection you don't do in small lesions, or you don't suggest to do in other centers in small lesions. I wondered how this was in Europe. Who does perform a standard subcarinal dissection? So we can just answer yes or no, I think. I'll just publish that poll. And then another one was indeed about the thoracic duct. Who does perform a routinely who routinely takes the thoracic duct in his operation? I think you do routinely. I'm not sure in Europe we do. So this is also something we could ask. But in the meanwhile, we can go to the questions. And Hassan Batirel already had a question, being most of the MI series have leak rates about 15%. Is it the same in Shanghai VETS series? What is the opinion and the reasons for the leak rate? I thought I saw in the robotic, I saw about 11%, and the other one was a little bit higher.
Yes, I think for the MIE, usually at the beginning, at the beginning of learning curve, a lot of surgeons just worry about the leakage. Even in China, I think it is the same, because for MIE, usually we need to do the McQueen approach. Not every is in China. So you need to put the stomach cannula very high to the neck, so usually the blood supply is bad. I think the key point for the higher leakage. But just as I said in my slides, I think if you try to make the stomach and the cannula very narrow, and you do the cocoa release, and you do a very high anastomosis in the neck, I mean, your leakage will be decreased. I think, according to our experience, if you do it just as I said above, I think you can decrease your leakage to the 5%. And usually this leakage is very minimal. I mean, it's harmless. If you try to divide it according to the five division of the complications, you can control it at just stage 1 or stage 2. It is my experience.
Okay, and the second question was, what percentage of was the leakage in the open operations? Is there a difference between
There's the duration difference, because now, in the past 5 years or in the past 3 years, so open operation is only used for the, salvage surgery, for the T4 surgery, and for the, complicated status.
Yeah.
So we cannot compare the open to MIE. What is the difference on the anastomotic leakage? I think it should be same. But actually, in my opinion, I think if you do the candidate harvest, maybe you can protect it better. Maybe it can decrease the leakage, but maybe there is more damage for the primary function.
Okay. And then the next question was, what type of anastomosis do you prefer? I know you make a circular anastomosis, a mechanical. Is it still the same one you do?
Currently, we usually use a mechanical round stapler anastomosis, not hand throw, because I think it's very reliable and reproductive, and it's very easy, and the residents fellows can do a learning curve very quickly.
Yeah. And then correlated to that, what is the percentage of strictures then? Because you don't do the soon one, you do the mechanical one.
Yes, I think this is a very good question. If we use a mechanical anastomosis, usually the stricture, the percentage usually is a little bit high. So in my population, in my patients, this rate usually above 30%. Especially for some patients, there's a leakage. Usually there may be a very serious strictures. But if there's no leakage, this stricture usually is reversible. If you do a 2 or 3 times dilation, usually the patient is okay.
Okay. And what do you use? What number do you use for the mechanical? Is it 21, 20, 23, 25?
25.
25.
Yeah.
Okay. Then indeed it should be okay without that much strictures. And another question was, do you suggest a pyloroplasty or not? You do a Kocher maneuver. Do you also do a pyloroplasty or?
In China, usually we do not do the pyloroplasty. We never do it. I don't think it's necessary, because especially now, we usually do a very narrow stomach conduit. So the volume stomach is very, very few. The content in the stomach is very small in the thoracic cavities. So according to the Laplace principles, if the content, if your stomach size is very small, usually the empty function is very good. So I think, okay, we need to do the pyloroplasty.
What we have seen in our series is when you make a very narrow tube, that is that the first day postoperatively, you get a swelling of the tube, maybe because of manipulation, of not because of I don't know what, but I don't know if you see that. We also make a tube of not more than 4 centimeters in width, and after a few days, some of them, not all, but some of them, they just dilate and they become very, very large in diameter. Do you see that?
Yes, this is a problem for the narrow stomach. I think the most important problem for the patients is for the early stage of after operation. Usually the patient, when they swallow the food, especially the first the first 1 2 swollen, when you sort of swallow the food to stomach, they need they need to put out the air in the stomach, because it's very narrow. So the food enter, then the air should come out. So there's a problem for them, and they cannot eat too much. But after several months, usually after 3 months, usually it can be improved.
Okay. Okay. If there are any other questions, people can still ask them, of course. And then I was interested in the 2 polls we made for the related to your talk. Do you routinely take the thoracic duct? So here, almost 80% does not. You always do, I think, also in the very early stages. So this is something only a few surgeons do here. But in contrast to that, the subcarinal lymph node dissection is done in more than 80%. So this is definitely also a huge difference, I think, between Europe, America, and the Eastern countries.
Okay.
Do you have any comments on that?
Yes, I like some comments for subcarinal lymph. Most surgeons like to do the subcarinal lymph node dissection because if we try to have more than 15 lymph nodes number, so we should collect more lymph nodes from the surgical fields. And the subcarinal lymph nodes harvest usually can increase the post-operative pathologic number of lymph nodes. Mm-hmm. I think this is maybe the most important reasons for surgeons to do this procedure lymph node dissection, not for the prevent metastasis.
Okay.
So yes, so if we needn't consider this number and only care about long-term survival, I think maybe more surgeons can avoid do this lymph node dissection in the future.
Okay. And
for the thoracic duct resection, I think is yes, it's controversial, and the long-term results is controversial because it's only some reports from Japan, from Korea. It's not very popular. I think we need more long-term observation for the data to have final results.
Indeed, I think in adenocarcinoma patients, there's not a lot of lymph node metastasis along the thoracic duct. So if it is necessary or not, it's questionable. But it's indeed interesting to see what the practice is. We already have a few new questions now.
Okay.
Do you routinely perform a feeding jejunostomy, or what do you do for postoperative feeding?
For the nutrition, we usually just to put an NG tube. So we put usually we do two tubes from the nose. So one is the NG tube for the drainage. Usually we take it out maybe just 2 or 3 days after operation. We will put another injectional tube from the nose for the nutrition. So we don't like the jejunostomy because we think usually we have 1% complications for this procedure. So we think we can put the NG tube is enough.
Okay, so and one J tube and one NG tube.
We put two tubes.
Yep.
One is the NG tube, another is the injectional tube.
Okay.
Yeah.
Okay. And then another question: what is the local regional recurrence rate, especially in the cervical area? Because there you do an extended lymph node dissection.
Oh yes. So for the local regional recurrence, I mean it means lymph node metastasis. It's lymph node recurrence. So in my center, usually it's 30%. I mean, in all of the recurrence, it account for 30%.
Okay.
Right.
Okay.
And for the cervical area, I think maybe account for the 50% for all of the local regional recurrence. Yes, it's very common, but for the upper esophageal cancer, we usually do the 3-field lymph node dissection, try to decrease this recurrence.
Okay. And then a question related to my question about the trachea. What is the tracheal necrosis rate? Indeed, you say we haven't seen that. We have seen some also of referral centers if there was a mediastinoscopy before, so the anterior side of the trachea, and then you also dissect the back side and the left and the right side of the trachea. You see some necrosis sometimes, especially after induction chemoradiation therapy. You have never seen that?
Yes, actually, I think if there's no leakage, I mean, there's no candidate necrosis, usually we cannot find any trachea necrosis. We haven't observed any just only trachea necrosis. I mean, all of the trachea complications come from the leakage.
Okay.
If the leakage, into the mediastinal, usually there's trachea esophageal fistula. Yes, for some patients, if there is an induction chemoradio, maybe there's some damage for the blood supply for the trachea. Maybe there's increased airway complication. But actually, I only observed one case is definitive chemoradiotherapy and 1 year later recurrence. So we do an artery resection. So these patients at last occur bronchial fistula to the third cavity. This is the only case. So I think for the definite chemoradiotherapy, especially above 60 gray doses, I think it should be dangerous. So for such case, can you hear me?
Yeah, for sure.
Okay, there's no video. So for such cases, we usually try to just to preserve the tissues and the lymph nodes, subcranial, and the healers. I mean, the healers lymph nodes. It will be helpful to keep the good blood supply for the airway.
Okay.
So this is yes.
Okay, and then last question was in patients after neoadjuvant radiation. I cannot.
Yes. I think it's okay. 5 years ago, we usually do not do the radiation for the neck because we think maybe there's a bad influence for the anastomosis. But now I think we also do the induction chemoradio and cover the neck areas. But the anastomosis is okay. We don't think it will increase leakage.
Okay, perfect. And then I wondered maybe one more question. I saw one of your first slides. There was a huge difference between the positive lymph nodes in position 2R and position 2 left. To right and to left. To right was 20% and to left was 10%. Do you have any idea how that is possible?
I don't know. Actually, I have wondered for this question for a long time. So why for the left side is a long path and more lymph nodes, but there's few lymph nodes metastases? Because for the right side, usually it's 20%, for the left side it's 9% or 10%. But it is the truth. I don't know why.
Okay.
Is it the data?
I didn't know if you had any explanation or not. Okay.
Yeah.
Perfect. I think it was a very good session with very nice presentation, good questions. I don't know if anyone has any urgent question, but we are already busy for 1 hour, and we are willing to let you sleep also a little bit, because it's 2 o'clock already there. Thank you very much, Professor Lee. Thank you to all the attendees. I think we were about 60 today, so this is very good. And I'll see you on the next webinar within 1 month about let's think about benign lung diseases. Okay, thank you everyone, and see you next time.
Yeah, thank you very much.